Today I'll be speaking on interlaminar full endoscopic discectomy, why and how I do it. Before we see why we do it, we will first understand how this surgery is performed. This is a representative case, a 42 years old male agriculturist. His history of pain in the left buttock and left lower limbs is 3 months. Pain is increased since 8 days. He's unable to walk, has difficulty in urination since last 2 days and constipation since last 2 days. Neurologically, his left EHL is grade 0. His right EHL is grade 3. Bilateral ankle deep tendon reflexes are depressed. He has saddle anesthesia and patchy loss of sensation in both lower limbs. Now, if you see the sagittal section and the axial section of the MRI, you see a large herniation at L4-5, which is extending cranially as well as caudally. So it's an inferiorly migrated and superiorly migrated herniation. The herniation is grade 3 and predominantly located centrally and bilateral paracentrally, predominantly on the left side. If you see the x-rays, there is a list and the level of the iliac crest is at the level of L4 vertebral body. Now, the patient position is in prone position on a radiolucent table with fully prepped and draped. An image intensifier free mobility is essential in this. Now, most important here is you would mark your docking point on the image intensifier, based on the image intensifier, and once marked, you would infiltrate the skin and the subcutaneous tissue and the muscle layer with some diluted adrenaline so that you have a bloodless field when you are making your incision. The lateral drape is important here because the image intensifier is going to stay in lateral throughout the procedure for you to guide in case you want to know your location. You make an incision of about 7 to 8 millimeters and then dilate the soft tissue with the help of a small mosquito, and then you may introduce your dilator. Over the dilator, you would introduce your working sleeve to dock at the right place on the cranial lamina. Before you put in your endoscope, this procedure is performed under constant irrigation, normal saline irrigation. So you would adjust all the draping in such a way that you maintain a sterile field, and as well you are able to collect all the water that is drained out during the procedure. The first thing when you put your endoscope, you encounter is the extraspinal soft tissue, which is attached to the cranial lamina. So you would first take off all this extraspinal soft tissue, which is absolutely essential. Also secure all the bleeders in the extraspinal area so that you don't encounter bleeding in the later part of the procedure. So all the soft tissue which is on the lamina and at the base of the spinous process needs to be removed for you to understand the gross anatomy. You commence your process of laminotomy by starting from the inferior articular process. So trimming the part of the inferior articular process medially, proceeding ahead with the cranial lamina and going towards the base of the spinous process. So the extent of bony decompression is going to be based on radiologically as well as intraoperative findings that you have the attachment of the ligamentum flavum. You would then start with your Kerrison rongeurs to do the remaining part of the laminotomy and trimming of the inferior articular process. Sometimes in the process of doing a laminotomy, you may encounter some kind of bleeding. So your diamond burr is handy. You can also use bone wax to stop this bleeding. You would continue doing the burring the base of the spinous process for you to have a contralateral access. I prefer to do it before I open the ligamentum flavum, and that is useful because then you are able to protect the thecal sac from inadvertent injury. So till if you once you have drilled the cranial lamina till the attachment of the ligamentum flavum, you would want to detach the ligamentum flavum from the cranial lamina and strip it off completely. In cases where the herniation is not so large, we don't prefer, well, I don't prefer to I don't prefer to remove so much of ligamentum flavum, but just make a small slit in the ligamentum flavum, or just do a limited phlebotomy to get into access into the epidural space. But here, since the herniation is pretty large and extending cranially as well as caudally, I would do a wide decompression so that when delivering the herniation, I don't inadvertently injure the neurological structures. Now, the Kerrison ronges in endoscopy are different variety. They are made of very thin foot plates, so you are able to gain access directly into the lateral recess to identify the lateral edge of the neurological structures. So here you can see that I'm decompressing more cranially as well as caudally to identify the lateral, define the lateral margin of the neurological structures. So once you have identified the lateral margin of the neurological structures, I would use a dissector. I would use a dissector to gently retract the tissue, neurological structures medially. So you can see the herniation is extruded, so it just pops out. So very gentle removal of the herniation is done. Here you can see the herniation coming out. So once the major part of the herniation comes out, then you would concentrate more on the cranial and the caudal migrated parts, and you use a kind of a nerve protector, retractor, to remove the remaining part of the herniation. This is the cranial part of the herniation after retracting the neurological structures. I would also do it for the caudal migrated part. Now here in the caudal migrated part, you can see a large herniation at the base. Now, before I remove this herniation, I would ensure that I have a good bloodless field in the lateral recess. So I use a radio frequency to secure all the bleeders in the lateral recess. We gently dissect out the neurological structure from the herniation because there is a chance that it may be adhered. And then gradually, I use the nerve retractor or neurological retractor to gently manipulate the neurological structures, and you can deliver the herniation. So once all the major fragments are removed, then you would concentrate more on the smaller fragments, osteophytes, and the intradiscal part of the herniation, which are loose fragments. So you can do the discectomy and also modulate the annulus with radio frequency device. So once you have completed the entire decompression, you would confirm by seeing the contralateral. You can see the root on the contralateral side. You can see the ipsilateral decompression. And this is the decompression ventrally in the midline. You can see the root here. The axilla is pretty caudal here in this case, and you can see a good pulsating thecal sac. Now we come to the question of why we do an endoscopy or why we do an interlaminar endoscopy. Now there are a couple of reasons why we do interlaminar endoscopy. So I would classify these advantages in three different categories. One is technical reasons for the surgeon. So it's ease of operating in the depth has superior visibility because of constant irrigation as well as the high definition systems or cameras. Limited bone resection can be performed, just what is necessary. This does not void the facet joint, has a shorter operating time of 55 minutes. In this case, you usually have it about less than 1 hour. The contralateral access is easy as compared to other minimal invasive surgeries. The advantages for the patient is it's a single incision, which is paramedial incision. It's sutureless surgery with no minimum to no blood loss. There's no pain, no minimal to no pain after the surgery. Usually patients stay overnight because these patients are operated under regional anesthesia. So prefer to keep them overnight. And the patient will be able to resume active lifestyle soon with rehabilitation or exercise program. The price for this surgery is comparable to open surgery as amount of consumables, anesthesia and hospital stay much less. And the technical advantages of endoscopy is that you don't do muscle dissection, it prevents secondary instabilities, and it's an advanced methodology for the patients. Hope I'm able to throw some light on why interlaminar endoscopy is useful and how it is performed. Thanks a lot for this opportunity again, and thanks a lot for your attention.